Hi, everybody. My name is Guillermo Sanz-Berney. I am a physician informatician. I started my medical career in Chile as a binational person and ended up in San Diego and UCSD doing a fellowship in nephrology. And then my geekiness drove me to informatics, clinical informatics. And through various experiences that eventually we're going to share through the series, it brought me to know Thanos through a joint collaboration that you'll learn later on, and in which we share the informatics concept and the informatics background, but we also share our passion of healthcare and how technology can affect healthcare.
All right. And I'm Thanos Melisiotis. I'm trained in emergency medicine. I've been practicing clinically for over a decade. But I also had, prior to medicine, I was involved in information technology and entrepreneurial efforts, and got my clinical informatics board certification, kind of combining my interests in both medicine and information technology with a goal of kind of just solving a lot of our problems that we have in clinical practice. Yeah, met Guillermo and the rest of our team who had similar concerns and desires. So it's an exciting time for us, and I look forward to all our chats about this, real world problems and the solutions that we're coming up with.
Sounds great. And I think it's a good segue to, you mentioned real world problems. And so we are going to be talking today about data, clinical data to be specific. And I wanted to point out in a little bit something we were talking beforehand with Thanos about real world data, where we are and where we should be. So that means exactly what the EMRs generate per se, and then real world evidence. And anybody who's involved in the clinical sphere know what evidence-based medicine means, and you can kind of segue into what real-world evidence is. Insight is kind of things you find out about the real-world evidence, and actionable insights, what you can actually do something about. There's things you cannot do something about. And I was wondering, what do you think about where we are and about EMRs producing real world data, and are we using it enough? Are we not using enough? Is it the quality lacking, or is it there?
Yeah, I think it's a great question, because I think there's a great differentiation between the data that's actually in the EMR. I think EMRs do a great job of collecting data. The problem is we have data overload, and there's not enough analysis of this data, at least a summary of it, or analysis of the data to create some form of again, analysis or even knowledge from that data. So, on one end, all these data points, on the other end, we have the knowledge that comes from knowing what this data means and how it applies to the patient's presenting problem or their overall health. And I think we're kind of in this very infant stage where we got data, we're trying to consume it from this fire hose. And it's too much data and not enough interpretation and perhaps like summary or assistance of it. So like this whole concept of, augmented intelligence, taking this, helping create these, loose even interpretations of what this data means to help us so that we're not overloaded and overworked. So there is a difference between, what's this real world data, what do we really want out of that data? And then I think that's where we're developing these tools now. It's like, really, how do you consume this data and make it actionable, like you said?
Yeah, and I think that to add a little bit to that, I think the motivation and that in general are distinct between, for example, what a health system wants for data and what, for example, a clinician wants from a data to create a clinical decision support application, as opposed to another application that generally wants to know how much we saw so I can get so much and reimbursed. How do you think we can tie in or we can merge these two different kind of incentives to create to generate data points and to use them, for example, for a clinical support as opposed to a billing?
Mm-hmm. I mean, that's a great question too, because I think there's we do want different things out of the data and out of the EMR, and there has been a lot of push or a lot of the incentive for these EMR vendors has been coming from administration, who are also the payers for the technology, to create the tools that they need to get their job done, which is, financial incentives. They want to make sure that the charges are all captured and the procedures are all properly documented. But, I feel like we have less of a voice less people or fewer doctors really pushing to get that clinical insight out of the data. I think we're still collecting the data, but we're not developing the tools to help, interpret that data. And that's partly because, we don't show up to a lot of the building meetings, or we're too busy clinically to participate in the development of these tools. So I think partly it's how do you get these docs involved more? And it won't just be clinical informaticists, like how do you get these clinical docs to have a louder voice and reduce the barrier of involvement? Because I think that's why they're not showing up. Like no one wants to sit in a 4-hour meeting talking about, where a button needs to be in order to make an EMR work better. You want to know that what you're using helps you do your job better.
Been there, done that. But but don't you think that, for example, I mean, my first experiences as a full-grown informaticist was actually an application, a population health application, which was the Medicare was paying these health systems to follow up in more, and with that came a lot of funding for specific diseases. And in my health system, it was COPD, stroke, hip replacement. I think MI was the other one. And I was brought in to do an analysis about the risks for COPD, and because the enterprise leadership was concerned about the false positive, and the clinical leadership was concerned about the false negative. And after a lot of analysis on that, I got like a year's worth of billing, and we saw a year's worth of BPCI, which is the bundle payment. And we saw, for example, that, okay, so COPD will give you this, but if somebody gets an infection, pneumonia, that pays more, gives a different DRG, which is the code that Medicare uses. And then if you got a sepsis, that pays more. If you got hooked up to mechanical ventilation, that pays more. So obviously, it's not that the billing people are up-coding erroneously. It's just that they're coding to a specific goal. And the clinical people were just like, I don't really care about false positive. I don't care if 10% of my patients are not COPD. I just want to cover, I don't want to miss anybody who is a COPD patient. And how do you converge those two worlds into one thing without generating, I mean, at some point, the clinicians will say, okay, whatever, just like, I'll just do what I can. And we suggested like a discharge summary evaluation, like post-discharge evaluation of the clinical file, so people can see, okay, we're going to follow up on this patient. But that's kind of a very old-fashioned way of doing stuff when you have technology that could help you. And I don't know how you can convince the business to look at this in a different way without them trying to think, because we have to be realistic. The bottom line does affect clinical care in this world right now. I mean, I worked before, right before returning to the US, I worked in Canada, which has a universal healthcare. And it's not a pro or con kind of thing, but there's a different vision about where health tech can help us. And this kind of concept where you think about healthcare before other topics. I don't know what do you think if there's any kind of solution to that? Is it about framing the question, or is it about people who are informaticists getting into more leadership positions? I don't know. What do you think?
Well, let me ask you this. When you were designing that project, were physicians, the clinical physicians, involved with the goals of the project from the get-go, or were they introduced later after the administration was the one asking the actual question?
They were introduced later. Yeah, I mean, it was the business at first. I don't want to say red flags, but they noticed that, for example, that of 100 DRGs that were included in the COPD program, which in itself was kind of wrongly defined because it included asthma, acute asthma, exacerbations, which is not COPD. But putting that aside, it was the business, and then the interaction with the pulmonologist that was became very clinical involved. So yeah, there was. I don't know. Yeah, that answers your question. Yeah, it does.
Right. I mean, you bring up this point where when it does start from a business like incentive, or the question really comes from how do you reduce these readmissions or representations because of the financial disincentives of coming back to the hospital. I think it's hard to align the motivations of the program because it's just a different angle from the get-go. I think getting the motivators from both sides, clinical and financial, from the beginning may help you kind of level the playing field from the motivation side. For example, like when we, COPD is a little bit hard because, but it is still, I guess, similar. In my mind, I'm thinking about national efforts from like congestive heart failure standpoint, where we're looking at 30-day readmits for heart failure, kind of similar. But there's a financial disincentive for everybody that's coming back to the hospital with readmissions. So from the admin standpoint, they don't want those readmits. Clinically, obviously, if there's treatment failure, that's one thing. There's either poor management from a medication standpoint, maybe there's poor compliance, social factors, whatever it is, right? As a doctor, you want to make sure that they're not coming back because of the, those clinical reasons. The end result's the same. They still come back in the hospital within 30 days. So I think you're trying to capture those, but the motivation of why they're coming back is very different. And I think if you align those two parties beforehand, you're going to get a better chance of participation from both sides to address that issue. I'm not even sure if I'm making that as clear as I can, because I think the incentive for the hospital is better reimbursements if you don't have those bounce backs. And from the clinical side, you don't have those sick patients coming back because of non-compliance. So it's, but a very different, I mean, the cause may be, the non-compliance, but the end result is, I'm dealing with the same sick patient, they're stuck with less reimbursement. So a little bit of a different end result.
I mean, yeah, and for those that don't know, who are not clinicians, COPD is a chronic obstructive pulmonary disease, and usually patients who have been ex-smokers in general. But the concept that you're right there, that what generated the conflict is that, for example, in COPD specifically, it was a 90-day follow-up in which they were assigned a specific nurse. So a nurse was following up 90 days post-acute. And if they submitted a DRG and the Medicare was saying, you know what, that's not what it was, so we're not giving you X amount of dollars that you're supposed to be. So that does affect a little bit both worlds, the business and the clinic, because the clinic, obviously, every year, I assume, will say, you know what, we're seeing X amount of patients, we need a bigger budget. and the business will say, well, your biggest expenditure was COPD patients, and we only get 50% of what you actually spend. So, and I'm not saying one is better than the other, but I just say how hard it has become to put both people on the same room and get to a middle ground. Because, I mean, obviously as physicians, we say there shouldn't be a middle ground. It should be healthcare and health wellness over anything. But sometimes we live in the real world and we know that some things need to be transactional. And at what level you say, why this is my red line. From this one, I cannot give you more because you're telling me to a little literally turn back on my oath, my Hippocratic oath. And so what do physicians do in that case? I mean, do you do things by yourself on the side? Do you find yourself working next to an hour, 2 hours to shift because you're doing this extra thing that the business wants to support with health tech? Or, as I said before, do you just find yourself looking into getting into positions to make decisions that are more clinically based and not totally 100% billing or profit based?
Yeah, I think the challenge to that is that these types of tools help tell you if these patients come back, or identifying, the ICD-10 or whatever it is that's applicable. So now you get this data, from billing perspective or financial perspective, they're like, okay, we're getting fewer reimbursements because of X reasons. From the clinical perspective, they're like, we're getting more COPD or CHF patients coming back to the hospital because of, whatever reason. I think the end result, though, from both parties is how do you reduce the sick patient? How do you improve their general health? Because if you address that problem, now you're able to solve for the decreased reimbursements as well as doing better, care. Those patients aren't coming back to the hospital in bad COPD or heart failure flares. So I think we have to step back and look at what the end result is that we're trying to achieve, and not so much necessarily the data gathering. But obviously, you want quality data. Like you said, you don't want those false negatives or false positives, depending on which person you are, from which side you're coming at it. But I think to solve for that, you still need to get those same players in the same room early on, so that you're designing the tools together, so that you both have the same outcome of getting that population. But then really the next step is finding out how do you solve for that problem, which is those bounce backs, the recurrent hospitalizations, and what tools can we develop to help, make that distinction, or, why they're coming back. How do you develop the tools to make that step a lot easier and more accurate?
So do you think that having an office like a CMIO in an entity should be giving us a little bit more leverage as people, as clinicians as a whole who look into data, as opposed to being, for example, I've known health systems in which they have a CMIO, but they're under the CTO, and so there's a lot of conflicting kind of interest there. As opposed, do you think there's a little bit more of education that needs to happen towards the health system to think that all these things that we talk about are as important as the reimbursement? Because the business can say, well, if we don't have reimbursement, we cannot give care to all these patients, which is a valid point. So how do you think that being more noticeable or being more loud, like, squeaky wheel gets the oil, is that the way to go? Or how do you think, what is the challenge for people who are in the world of health tech and informatics to get their voices heard as loud as other parties in the health?
Yeah, I think you had kind of brought up a couple of good points. One is like knowing what the difference is between medical informatics and bioinformatics and statistics. I mean, statistics plays a role in all of it, but I think it's just a different lens. And as a clinician, you want to look at the outcomes and the clinical significance of all this data. So I think I'm going to kind of lean on our examples that we're already using, just because it's a little bit easier. But for those COPD patients, I think my motivation as a doctor is to see how do I get those patients better care, and how do I get them to stop coming back to the hospital because their disease is not well managed. And I think that if I come up with, if I use these statistical tools and analyses, informatics to help come up with a plan of how that helps, that I improve outcomes, I think that gives a lot of motivation, or a lot of ammo for us to use to administration and say, hey, this is like, we're having positive outcomes by using informatics. And I think that's how you grow an informatics department within a hospital. And I think it's challenging in a small hospital to do that because they don't have the resources. In academics, you may have like a large informatics department with a CMIO and multiple people working on various projects. But it's still, like, I think those community hospitals probably are not going to get that same kind of resource to kind of have that, look at the data and get people looking at the data, like a staff, whether it's analytics and analysts or clinical informaticists to do that work. But I think if you have clinical outcomes, positive clinical outcomes, you could really make a case for growing that department. I mean, in your experience, do you feel like that drove some of the, I guess, growing the department for informatics where you've worked?
I think that there were two kind of roads that the health system was taking. One is innovation that would solve identifiable problems, and other were technology, like solutions, like in search of a problem. And I think that there were a lot of good efforts to try to solve, obviously, clinical problems that were identified by clinicians, but there's also sometimes a lot of hoopla for a specific technology, but there wasn't a comparison about, this solves 25% of our problems. This actually we don't know, because we don't know for what it will work, but it looks kind of sexy and it comes with a good UX, UI. And so I think at the end of the day, it comes about this kind of it's kind of not sad, but kind of in the state of who is a better used car salesman for the product. And sometimes, I mean, we both have kind of an outgoing personality, but a lot of people in our same kind of realm are not the people who are going to be standing on the soapbox and not whine, but say, you know what, this could be better, and this could be our solution, and these people in X place have solved the problem using this, and then you have it took legislation for clinicians to start adopting EMR. I mean, if we didn't have meaningful use, people would still be using, paper medical records, because they were used to that. They're used to their own kind of shorthand and their own abbreviations. Even myself, when I was doing clinical work, I had my own kind of stuff, and I have a horrible handwriting. So it goes with the stereotype about clinical people and the handwriting. So I feel like, to be honest, it's about selling to there's a lot of topics. I mean, about talking about what are your needs as a clinician, informatics people, if it's not their domain, but say, what is your need to the gastroenterologist with the oncologist? I mean, I learned a lot when I was put in charge of the new HIE for this health system. I learned a lot about, oncologists' view of data, not the same as, a family medicine practice or even an ED physician, I was showing them that we have an HIE that have, for example, 2 or 3 years of lab data. And they were saying this is not useful for us because we need minimum 5 years of lab results to have an idea of remission or the new word they use, free of disease. And so it, I don't know what I want to pivot a little bit into the world of HIEs and sharing information and legislation around data. Do you think that that's the one that is, do you think that we need actual government legislation to push innovation? Or do you think that there is enough knowledge in the world of clinical medicine to generate these kind of innovations by itself?
We started this whole medical records, electronic medical records initiative to solve specific problems, and we were hoping that it'll be a solution to some of the inherent problems of medicine and having access to information about a patient's medical history. I think that was one of the main goals, but it took us a long time to get that result, right? Like we were not seeing any of the benefits of EHRs for a long time after it was rolled out. And then you could kind of contrast that with what's going on in Canada, who doesn't have that incentive. Is there an improvement in medical care because of the EMR? Like, I don't know. Like, I don't even know if we've even scratched the surface. And that's partly because it's all data right now, and it's data that we can't really interpret easily. There's too much data, too much data that's disorganized. So when we're adding another source of data with these health information exchanges, we'll be able to access a patient's data from across the country. And regulation is going to make that a little bit more possible. But in the end of the day, if we don't have the right tools to help consume that data and create it into actual patient insights, I think it's just going to be another one of those, oh, we could do it, but so what? I think it's a lot more exciting when we start bringing in some of the technology solutions like machine learning and artificial intelligence that helps that next step, which is consuming that data. And how do you make sense of it all? And again, it's not meant to replace what we're doing as clinicians, but help, decipher some of the information overload that's coming our way. And I think that's what we're doing here at QiiQ, right? Like we're trying to create these tools that are not just another, presentation layer or another data point. It's really consolidating all that data and creating some insights while we're creating tools that help us, move through the different tasks that we have to do. And I think that's what's exciting. And I don't think it has anything to do with regulation. I mean, obviously regulation can affect these tools that we're creating or how fast we could deliver these to the clinicians. But I don't think regulation is what's holding us up. I think it's innovation and having the right people in the right place creating these tools. And I think that's the challenge. It's because, docs are practicing medicine, data analysts are analyzing data, and these clinical informaticists who are existing in both worlds, maybe there are not enough of them. Maybe they're not given the right tools or resources to create these tools to help the medicine get better instead of waiting to see, what happens.
And to counteract your point, and that it's like I spent 2 years in Montreal working for an oncology company, and that was the first time I saw my own experience as a patient, not even as a clinician informaticist, as a patient between a universal healthcare and the system that we have in the United States. I mean, Canada is so much behind I mean, we were when I was in my first job, we were so urged by the sense that we were not meeting the 2014 move from I-39 to I-10. And in Canada, I mean, I-39, you're lucky if you get it. So that's why, I mean, I'm not advocating for universal healthcare or against it. I'm just saying that's why I think the problem becomes the motivation or legislation. And that's why I have this conflict in my own view between letting each state or province in Canada go ahead with their own idea, and their own idea is that we can treat patients, but we're not in the red, as opposed to, okay, you know what, guys, by 2025, you need to have X, Y, and Z. And I think that letting everybody to their own devices, my position is a little bit more pessimistic than yours, and saying that I think you need a little bit of a push from any entity, government, private entity, to get things into innovation. I think that the human and the clinical informatics world, there's a lot of smart minds creating or thinking about a lot of smart things, but they're not getting all funded. And so there's the kind of artificial weeding out of the people who are actually thinking outside the box and those who are thinking inside the box to do the same aim as the business. I don't know if that came across what I'm trying to say, but it is kind of, for me, it's like kind of, there's a lot of optimism waiting for innovation to come and be sponsored and be funded just by the innovation per se, and not the problem.
Yeah, I mean, that's true. I mean, if you regulation and any kind of legislation and regulation will help push these innovations forward, or help drive them. But I think in part, it's because we haven't been able to prove that these innovations have a clear benefit. And I think that's one of the problems. Now you're talking about, EMR deployments that cost like billions of dollars to a health system. Like, if you're not seeing outcomes, improved outcomes by those decisions, like, how do you justify that cost to a healthcare system that frankly doesn't have the money to roll that out? So I think part of the solution to this is showing that you have outcomes, improvement in outcomes. When you do that, it makes it a lot easier to help, lobby for these innovations. Whether it's an EMR deployment or health information exchange, third-party tools, anything like that, right? Like, you have to show that there's some benefit. And I think, my question to you is, like, do you feel as a patient, or, being involved as either as a clinician or as a patient in Canada, was your care or your ability to care compromised by not having the same set of technology that was available in the US?
Okay. As I was telling you, like, it's obviously you realize what can be, as opposed to in the Canada world, what isn't there. And for me, it's like the basic. I mean, there's obviously, when you have this disparate kind of legislation. I mean, if you have, for example, insurance here in the States that covers medication, and in Canada, Medicare, which is the universal healthcare, does not cover medication. All of the things that, I mean, you say, oh, they're just saving money. No, like, even for things like compliance, that data point is so important that if you have everybody covered in medication for a pharmacy, you can have a tool that goes to, why this person diabetes? Well, this person actually filled their prescription for insulin once and then never again. And those are things that it's very hard to sell to somebody who's trying to reduce costs to increase the coverage of the population. So I think that there's in the Canada's case, in the US, and we're talking about Canada because we have a strong link with Canada as a country and as people who work in this project with QiiQ, we can see that. I mean, we're not saying that there isn't red tape in the States. There is a lot of red tape in the States, but there is kind of an exacerbation of the level of puzzle pieces that need to be addressed at the province level, not even in the country level. And I think that that is affecting the care. As a patient, I think that it does affect the care in the sense that I can go to one doctor one day, I can go to a second doctor one day and say, just to get more prescriptions of clonazepam or whatever, and it does affect the care that there isn't. And this goes to one of the topics I think we're going to address probably later on, because it's going to be a long concept, about the longitudinal medical record. It's like even in the States, we have all these medical records. If I go to, for example, when I was working in New York, we had this this concept of the winter birds in the winter that go to Florida for the winter. And what was happening is that they were going to Boca, for example, Boca Raton, and they were getting care, and they usually showed up only for the emergency in general, and they didn't have an idea of, they had a replacement, a valve replacement, or was a serial number. So we were trying to generate kind of a interaction between this health system in New York and Florida, and we created some sort of interaction between RHIE, create a VPN, a virtual private network, so there was kind of security, and so that the emergency docs were able, for example, if somebody shows up and get the records without having to go through a whole hassle of faxing them over and finding the assistant to send them over. And that's where I feel that there's a lot of pluses we're having an HIE or a RIO come. But I feel that, and this is another case in which the need actually is creating the innovation. So we have to find works around between HIPAA and resources and how do they can access our HIE. But I think it was a worthwhile kind of solution for people in a more mobile world where people are moving around and they go to this kind of physician, or even people want to go to specific specialists because they know they're renowned for treating X disease. I think it's very useful. The problem that I feel that is happening is that we are still far away from creating, and maybe the patients, and this is my view, I think patients are going to be the motivators or the trigger to create this longitudinal medical record when they have the USB and they go to the physician and they load their data and they go everywhere with their USB. And so they have this historical thing in which there isn't an incentive yet in general for health systems or urgent centers or emergency defenses to share the information. Or to create the infrastructure to sharing in live. I mean, that's what you do who works in the emergency department. I mean, we had this whole concept of behavioral health tagging. So that means that certain diseases or certain patients, the information is not shown unless you have your psychiatrist or psychologist or a recovering alcoholic social worker. And so you have to create, for example, a separate kind of login for ED patients because they don't have the time to be asking and worrying if this patient out their meds, their lithium is too high, etc. And so there is kind of I think there's a missed opportunity here in which you're seeing that there's an issue. People are talking about the issue. There isn't one voice. And when I go to these conferences, like you go to the emergency department, I go to like the AMIA kind of conference. I think there's a knowledge, there's certain problems there, but I don't think there's somebody taking the mantle to solve it. And that's where I think maybe the government should step in, maybe not. I don't know. I feel that we just cannot wait until the general population feels that there's the need for investment in this section of the social intervention.
I mean, you mentioned a couple of great points also, and I wanted to like kind of talk about a couple of those, in part because you mentioned, this specific problem that you guys were addressing about patients traveling and the mobility of records. Because there's two things, right? Like there's portability of the information two sides of it, I guess you could look at. One is making information portable versus making information accessible or shareable from, depending on if you're looking at a decentralized versus centralized information infrastructure. Personal health records, when patient gets to walk around with their own information, whether it's on a USB stick or if it's saved on the cloud, like in a health vault. They've tried that model before in the past, and those seem to have not taken off as well as we thought they would. Microsoft Health Vault was one example. Apple has their own health kit. Well, that's the technical side of it, but they have their health. I forget the name of the service, but there's Google had their service. Like all of these companies tried standing up a personal health vault of some form. So it's a longitudinal record for that personal health record. But people almost, I feel like they're not ready to take on the responsibility of being the custodians of or managing that information, whether it's a distrust in any of those companies, or if it's just simply, having to log in and allow the permission to have that information shared to that vault. So, I would love to be able to do that. And part of the 21st Century Cures Act was to allow this information to be open and available to these patients so that they could download it and share it to wherever they need to, so that record exists. So that's on the one end. And then on the other end, you have this, other side of it, possible solution, which sounds like what you guys were trying to solve for, was, how do you make these health information exchanges more accessible? How do you make that information free flowing from the source institution, breaking down the silos, as we always say. And I don't think that we're as far as we are with personal access to your information as we would like to be from entity access to the patient's information with these health information exchanges. And I think part of that is happening. The ONC is helping promote the federal HIEs, and there's some other motivations, regional information exchanges that will help that problem. But in the end, if you don't have these small hospitals or clinics or anyone else contributing to that information exchange, you're still limited. You still have that problem of that. It's not that the information doesn't exist. You just don't have the channels to share that information. And I feel like those small private clinics aren't going to be able to, unless there's the tool there available or their EMR allows them to do it, they're not going to have the means to share the information. So I think it's interesting, we're at a time where, we are promoting sharing information from a patient side. There's a lot of work to be done to help support institutions sharing, because like you mentioned, hospitals are, they treat this as proprietary data. It's like their patient data, not the patient's data. So we have to either disincentivize that behavior, which sounds like it's been a lot of the motivation to moving forward is penalties, financial penalties for the people that don't do it, or perhaps help drive the incentive side of it. We have an interest as clinicians that we want access to this data, and patients would want access to that data so that they could get better care, whether it's they're flying from New York to Boca, or across countries even. I think we talked about international health information exchanges. So that's the future eventually. If I'm traveling to Greece or you're flying to Chile, you have access to your information wherever you go. And I mean, that's the ultimate dream, right? Complete, comprehensive, longitudinal record, no matter where you are in the world. That's a great place to be. Obviously, it's got it has a lot of security, privacy issues around that idea. But I would be excited about having that information available from a clinical side as well as being a patient. If I had a very complex medical history, like how does that not benefit me, and how do you promote that idea to, to the politicians, to Washington or to Ottawa, whoever it is that making those decisions, to help, move that goal forward. Because I think that's everyone's goal, right? Like, I mean, I think that's patient driven and clinician driven. I think that's what we want.
Yeah, and I think it's going to be the segue to our closing statement for our first quick conversations. Is that this is where I agree with you that, and this is where I go that we are not yet there. We're not there yet regarding real world data, in the sense that we are. For example, we were in RHAE in New York. There was also a regional regional health information exchange called HealthX, and I would get these bug reports saying that this patient was shown as deceased, and they were right in front of them seeing then an appointment. And people might say, "Oh, it's a huge deal that somebody is considered deceased for many reasons, right?" Besides the people who have to interact with somebody, it's like, why are you here? But second, it's like all these issues. So that's where I want to segue to probably our next topic of the next session of quick conversations is regarding EMRs. It's like, do you think that the consolidation of EMRs, because we talk about the United States a lot, because that's where we live, etc. But do you think the consolidation of EMRs is a good thing for this transfer of information, or do you feel like these big name EMRs are reluctant to be shareable? Like, for example, in New York, we were using inner systems for our HIE, and it wasn't, it wasn't good. I mean, if you asked a lot, you would get this kind of hack to be able to interact with other people, but it's not like born to be shared to a point. And just to end this up with a kind of question for next week, for next session, is do you feel like the EMRs should be more specifically regulated in the sense that the data that you collect is not yours, it's everybody's data? Or do you feel like there is still some room for them to grow in them themselves?
Yeah, I mean, I think for one part, I don't think the EMR ever thinks that it's their data, right? Like, I don't think a vendor will say, make that argument that it's their data. I think that they can make the argument that I guess their counter argument to sharing would be a security and privacy control issue. So they may, whole information blocking would come from the side of, hey, we want to protect our clients by putting up these barriers to sharing. But by doing so, if you are the major provider, if you're the major software vendor, you now have a monopoly on this data. And it's also a marketing tool, right? Like, who doesn't want to be part of that network, like inherently by buying that software? And I've been in at least 2 local health systems where I practice, where they've made decisions, or that's been a heavily influenced decision on the EMR vendor based on who else is using that vendor in the local area, because it'll make it so much easier to share that data with the other hospitals. Like, that was one of a huge factor in deciding which vendor to go with. But whether you're Epic and you have Care Everywhere, which is their health information exchange essentially amongst the Epic users, or if you have Cerner and you're part of the Commonwealth Alliance, which is more of the philosophy of a health information exchange. So there's multiple vendors that can be part of that. Like, once you buy into that vendor's ecosystem, you will, have your own information exchange. But I think the next step is really, how do you get these vendors to now join one overarching health information exchange? So you take away that need to have regional health information exchanges. Now the vendors can communicate amongst each other's. So you don't need that federal infrastructure. And I think we're moving towards that now. I mean, like even Epic, I think is having, if I remember correctly, the latest discussions were, or some news about joining Commonwealth or having some form of exchange with Commonwealth, which I could see that as like as a solution to having a vendor supported health information exchange, which will get us to where we need to be. And I think we're going to get there faster if we have federal incentives or federal regulation requiring it. Like, why not make these vendors have to talk? Why are we like allowing that to happen? I mean, Europe has made Apple create a USB-C connector for compatibility.
Like so happy.
They're able to get people to change, or a large company to change their hardware so that it's compatible with the rest of the country or the rest of the continent's standard. Like, why can't we? And that doesn't affect care, right? That's just a convenience. Arguably, can make it sound like electronic waste. But we're talking about people's lives and healthcare, and we can't make these vendors communicate with each other. To me, there's like a huge disparity there, right? Like, that doesn't make sense to me. So I'm hoping that we can have those conversations and possibly, play nice and help reach that common goal of communication between all these vendors, and make that possible.
I agree with 85.7% of what you said. But
I'm more interested in what you didn't agree with, but
I'm not giving that away. It's going to happen in our next quick conversation. Okay. And it's going to be, and I think that we were talking with Thanos about what formats we could use, and probably there's going to be growing pains. But I think there'll be a good topic to start next in a conversation about EMRs in general, where they are and where they should be or where they're going. And also, we should be able to create a mini journal club. I think we can both identify a paper that we could share it to each other and see what we thought about it and have a conversation about that. I don't know what you think about that.
Yeah, I think it's great. I mean, there's so much news in health information technology right now. There's a lot of both from a medical standpoint, also from a informatics standpoint, but also even financial standpoint, like all these entrepreneurial efforts, startups. There's a huge health information technology startup scene, which we are part of, obviously. And there's so much being done in information sharing, mobile tools, clinical decision support. There's so much going on. And I think that kind of focusing a little bit of topic wise and what's going on in the news will help kind of focus our discussions too. Cause I could feel we could talk forever about every single one of these and personal experiences and having a little bit of information, what's going on in the real world with papers and such will help kind of fuel these discussions.
Yeah, I think that, I think you and I want to get tired of geekness overload, and I think, but we don't want to impose that on other people who are listening to this. And I want to close the conversation regarding exactly that. I think pharma, big pharma, whatever you want to call it, also has been very active in pursuing these kind of EMRs, because I had a conversation or relationship with Regeneron a few years back, and they had a lot of genetic data or bioinformatics, and they were trying to match that to. I was telling them there's ways in machine learning to generate clinical phenotyping of genetic data. And obviously that's a huge, because it's a huge thing for the company and for the world in general to to eventually come to the personalized treatment, you know, for anything. I mean, not just cancer, which you usually think about, whoa, genetic or HIV. We think about, I mean, think about the whole world of
Precision
transformation.
medicine, right?
Yeah, where you actually have EMRs collecting your DNA information and saying, you know what, this patient is actually, even though you would treat this patient with vancomycin, you know, at first level, this genetic trait actually makes them, you know, very resistant. So we should try with a second level. So I think that I think it's very interesting to see where EMRs can actually improve themselves using their own data and helping treatment and also helping, you know, compliance. And I think this will be a fascinating topic for our next conversation, and I look forward to it.
Yeah, I mean, I could probably talk a lot about phenotyping and precision medicine as a topic of its own, but I think what enables that is like the foundation of, you know, the EMR, the data structures, and then of course the sharing of that data. Because if you just have one single data point or source of data, you may not have a complete picture. So that's yeah, all great topics, and I look forward to our future discussions on all of them.
Sounds great. So this is Guillermo. I'm saying goodbye for today. Hope you guys are gentle with us. It's our first time creating a podcast regarding these topics. It will get only better. We cannot get worse. You can only get better. And so thanks from my side.
And I'm Thanos signing off as well. And I appreciate your time, Guillermo, and always love our talks.
All righty. See you later. Bye.
See ya.
And see you, Thanos. Bye-bye.
Bye-bye.